Hello and welcome to Triage, timely conversations for healthcare professionals, a podcast created and produced by K&L Gates. Each episode is designed to highlight important developments in health law and analyze the impact on our clients and friends of the firm. We hope you enjoy this podcast.
Hi, I'm Gabe Scott, an associate in the firm's Research Triangle Park office, and I'm joined today by my colleague Darlene Davis, a partner who is also in the RTP office. In this episode of Triage, we'll be talking about the PAMA regulations that require reporting of private payer rates for laboratory tests to Medicare. In light of the upcoming data reporting period between January 1st and March 31st, 2023, this episode will discuss the reporting requirements and potential penalties for failing to report. So, Darlene, can you give some background on where this requirement comes from and what the purpose is?
Sure. In 2014, Congress enacted the Protecting Access to Medicare Act, which is also known as PAMA, and specifically Section 216A amended the Social Security Act to add a new section which changed the methodology for how Medicare payment rates for clinical diagnostic lab tests are determined. CMS then promulgated regulations that were finalized in 2016, and then the regulations were again amended in the calendar year 2019 Medicare Physician Fee Schedule Final Rule, and again as part of the calendar year 2021 Medicare Physician Fee Schedule Final Rule. So the statute and implementing regulations require CMS to collect information about private payer rates for lab tests from each entity that meets the definition of an applicable laboratory. And CMS then uses that reported data to set payment rates under the clinical lab fee schedule, generally based on the weighted median private payer rate. There are other exceptions for certain types of tests. So the first round of reporting under this requirement was between January 1st and March 31st of 2017, and that was based on data collected between January 1st and June 30th of 2016. We're currently in the midst of a second round of reporting, with the reporting period having been delayed several times by statute due to the public health emergency. So the reporting period was originally set for January 1st to March 31st of 2020. It was delayed to 2021, then again to 2022, and then at the end of last year, it was delayed again to January 1st to March 31st of 2023. So the data collection period for this current reporting cycle has not changed. However, it's January 1st, 2019 to June 30th, 2019. After this current round of reporting is done, the data reporting for clinical diagnostic lab tests is then on a 3-year cycle, so that the next reporting period will be in 2026 and then followed by 2029 and et cetera, absent a statutory change.
Great, thanks, Darlene. So you mentioned that reporting is required by applicable laboratories. Can you explain what that term means and who it includes?
Yeah, sure. So in order to know if you have any entities that are required to report, you have to assess whether the entity has any components that meet the regulatory definition of an applicable laboratory. And that is a definition that has several elements that really, kind of need to be unpacked and looked at individually. That means an entity that, number one, is a laboratory as defined under CLIA. Just a reminder that includes locations that only performed wave testing under a CLIA certificate of waiver. The second criteria is that the entity bills Medicare Part B under its own NPI, or National Provider Identifier. And determining whether this criterion is met is more complex than it may seem based on that language, because it really isn't the same thing as saying the lab has its own NPI. There's further nuance to this criterion because for hospital outreach labs that bill Medicare Part B on a CMS 1450 under bill type 14X, they can also potentially be applicable labs and meet this definition. And this is a key change from the calendar year 2019 final rule, which I'll come back to. The third criterion is that in a data collection period, the entity has to receive more than 50% of its Medicare revenues, and that includes Part A, B, and D, and any associated cost sharing for services furnished during the data collection period from either or both the clinical lab fee schedule and the Medicare physician fee schedule. So this criterion is called the majority of Medicare revenue threshold. And there was a change in the calendar year 2019 final rule to remove Medicare Part C or Medicare Advantage from the denominator. And CMS's goal in doing that was to actually try to increase the number of labs that would meet this criterion. And then the final part of the definition of applicable lab is that the entity has to receive at least $12,500 of its Medicare revenue from the clinical lab fee schedule. And with an exception for a lab that offers and furnishes an advanced diagnostic lab test, this $12,500 threshold applies with respect to all CDLTs or clinical diagnostic lab tests, but not the advanced diagnostic lab tests that it offers and furnishes. So this $12,500 threshold is called the low expenditure threshold. So I'm going to go back now to the point that I mentioned in the second criterion about outreach labs. Prior to the calendar year 2019 rule change, it was typically the case that unless a hospital had a separate MPI for its lab, the hospital wouldn't meet the definition of applicable laboratory because more than 50% of its Medicare revenue is typically from the inpatient prospective payment system and the outpatient prospective payment system. So the change that CMS made in 2019 is significant in likely capturing many hospitals to the extent they perform outreach work. And this is because only their bill type 14X Medicare revenues are considered under the majority of Medicare revenue threshold. And their Medicare revenues are primarily, if not entirely, derived by the clinical lab fee schedule or the physician fee schedule or both. So the bottom line there is unless bill type 14X revenues from the clinical lab fee schedule are less than $12,500, hospitals with outreach labs that bill under the hospital MPI are likely to have to report in this round. As a reminder, and this was true in the first round as well, physician practices may also have to report. Again, they will likely meet the majority of Medicare revenue threshold, particularly with the removal of Medicare Advantage from the denominator, since their Medicare revenues are, again, primarily, if not entirely, derived from the clinical lab fee schedule and physician fee schedule. So again, unless their revenue from the clinical lab fee schedule is less than $12,500, they will likely have to report as well.
So once an entity has determined that it has, one or more applicable laboratories, what information then do they need to collect and then report that information?
So good question. The regulations define that term in terms of what has to be collected and then reported as quote unquote applicable information. And that is information that has to be reported for each clinical diagnostic lab test that's furnished by an applicable lab during the whatever the data collection period is, which again, currently is January 1st through June 30, 2019. So the particular data elements include each private payer rate for which final payment has been made during the data collection period, the associated volume of tests performed corresponding to each private payer rate, the specific HCPCS code associated with the test. However, this does not include information where payment for a test is made as part of a capitated rate. So, as with the analysis of applicable laboratory, the collection of applicable information is not as simple as it might seem from the definition. So, for instance, there are defined terms that are embedded in the corresponding elements for applicable information, such as, what is considered to be a private payer rate for purposes of this rule. And there's also a lot of sub-regulatory guidance, such as, what constitutes a final payment and also addressing other matters.
Great. Thanks for that detailed summary. And so, when we think about an obligation to report in CMS's monitoring of that, what do we anticipate in regard to CMS's future enforcement efforts in this area?
So good question. as you noted, there is the ability for an enforcement mechanism built into the regulations. And so the regulations provide a civil monetary penalty of up to $10,000 per day. And that's adjusted annually as HHS adjusts the CMPs every year. And that can be applied to a reporting entity for each failure to report for its applicable labs, or each misrepresentation or omission in reporting applicable information. And so for 2022, the current amount of that penalty with the inflation adjustment is $11,649. And again, that's per day. So to my knowledge, CMS didn't do a lot in the way of enforcement in the first round of reporting. Likely they were understanding that, this was the first reporting cycle. And then, of course, that was 2019 and, 2020, we've, really been dealing with the public health emergency. Having said that, however, I would anticipate CMS will engage in greater enforcement with this round and future rounds, given the concerns that there weren't enough reporting entities in the first round. And as discussed earlier, CMS's attempts to broaden the entities that are required to report with the changes they made in the 2019 physician fee schedule final rule. And then finally, because of the impact that it has on payment rate setting.
Yeah, it seems like if CMS is going to be basing future rates on this information that they collect, they certainly would, prioritize the collection of these rates. And so I think we would expect that there may be enforcement efforts in this area. Given the complexity of this issue and the upcoming reporting requirements in 2023, Darlene, are there any, final thoughts that you'd like to leave our listeners with?
Yeah, so there is a lot of work that goes into determining what is an applicable laboratory and then collecting all the applicable information that needs to be reported between the January 1st and March 31st, 2023 reporting date. And this information can be voluminous depending on the size of the organization. However, given, the statutory delays that we discussed, there is still time for folks to start the process if they haven't, but I would recommend doing it as soon as possible. And for organizations that have paused their PAMA process in light of statutory delays to understandably focus on the public health emergency, I think we would note there's no guarantee of another delay. So, folks may want to get their processes restarted as well, again, with that January 1st to March 31st, 2023 reporting deadline in mind. And then finally, as I noted several times, the interpretation of the language in the regulatory text is not intuitive. There's a lot of sub-regulatory guidance that is both in the preambles to the final rules and also on CMS's PAMA regulations website. That really should be taken into account. So I would recommend consulting with your legal counsel early in the process to ensure the terminology is being interpreted and applied correctly if there are any questions. And additionally, CMS has been very open to receiving and responding to questions where additional guidance is needed. So that's another source of clarification. And the CMS email addresses to submit those questions to are on the CMS PAMA regulations website.
Darlene, thanks for these important insights. And thanks to our listeners for your interest in this triage episode on reporting requirements under PAMA of private payer rates for lab tests. We at K&L Gates will continue to monitor developments in this area. But in the meantime, please feel free to contact us if you have any questions. Thanks again.
Thanks again for listening to Triage, timely conversations for healthcare professionals. New episodes are available for download through Apple Podcasts, Google Podcasts, and Spotify. By subscribing to Triage, you will receive timely notifications for each new episode. Also, if you have any topics you would like to hear discussed on Triage, please don't hesitate to email triagesupport@klgates.com. We would love to hear from you.